Yes.
Thank you.
We'll have the next speaker, the Dr. Hazem Rashid. He'll be talking on the invisible cataract.
Very expensive. Only through that it's possible.
Good evening, everyone. Thank you very much for organizing committee, and thank you for the chairman. And thank you for the audience to be so patient with us at the end of this very long day. The topic has been coined quite a few years ago with Professor Kaufman, Herbert Kaufman. Of course, it's a very tricky issue because it's not the matter of not seeing any opacity and then telling the patient that, oh yes, you do have a cataract, and then I run to the operating theater and make the cataract. No, there have to be some objective findings. Okay, this patient is complaining, but I should find a justification for this complaint to be to give me a reason to proceed so that the patient benefits from this. These cataracts are not like soft lenses or nuclear sclerosis. This is actually after that when we see it. It's a cataract. We cannot see it on the slit lamp, whether it be by the red reflex or by the slit. It looks like a sclerosis, but actually during the surgery it chops and rotates and behaves like an actual lens opacity. So this is a group of patients in which cataract surgery is justified. So how do we pick them up? How do we give enough reason to them, objective reason, that they proceed with the surgery? This is the status of the light scatter of this patient before the surgery and after the surgery. Before the surgery, it was still in the green level, but it is a little bit deteriorated. And after the surgery, it is much, much better. This light scatter is measured by the device, the HD analyzer, and it works by projecting a point source to the retina. Simply speaking, when the retina has one point, then it is a good optical quality. When this point is spread and it is not pointed anymore, therefore it is a lower optical quality. There is a number for each of these patterns. In the first range, there is the less than 1, which is good quality of vision. The 1 to 2 is what we are talking about in these patients, because now we have enough expertise and we have good equipment enough to offer them a good help. Of course, the 2 to 4 and the more than 4 OSIs are frank cataracts. So during the past year, we examined 2,500 patients, which is about 5,000 eyes, excluded those eyes which had frank cataract, which had scattered the OSI above 2, and started the analysis on the rest of the eyes. Of these eyes, we found that there were 483 patients who were complaining of some visual deficit or had any visual complaints. They had a very, very clear pattern. The mean OSI, the mean scatter was higher than what they were used to. And all parameters were consistent with this. Of course, we don't run and tell the patient, oh, you have so-and-so, you have to come. No. This is common and justifiable to do when these above 40 patients are, this specific example was in the 50s, in the late 50s, but patients who have low hypermetropia, they can neither see far nor can see near, and above this there is change and decrease in their visual quality. To document it, we need to make sure that the ocular surface is in good condition, because the ocular surface and the dry eye itself causes increase in the light scatter. So if you don't have a very good ocular surface, and then you put a trifocal lens like these two patients, like these two patients, the screen on the left, the graph on the left, has to do with a trifocal toric who had very good ocular surface. And already the trifocal lens increases the light scatter. So this patient is falling in this range, in the yellow range. So if you increase the light scatter because of the dry eye and irregular ocular surface, then it passes up and the visual quality becomes much less and less. So there is no benefit. If the patient is already coming with a light scatter of around 1.3 according to the calculations that we just saw, and then you increase the light scatter to an average of 2 with these lenses, and then further increase this because of the dry eye, then you are really giving this patient a very, very hard time. To recap again, I know that we need to be very objective when we are not pushing, but we are just telling the patient that this is an option. We need to be objective. Not many of us have this HD analyzer with measuring the scatter, but there are other devices. The dysfunction length index with the eye trace is okay. The meso test, which is usually used for driving, another one by Oculus. The Sequant is very, very close, which measures the stray light. And then, of course, if you don't have any of these, then we need to check the contrast sensitivity. If we have the machine for the equipment for the glare sensitivity, it's good to do. And all of us have the Pentacam. We can also look at some opacity objectively. But again, it's looking at an opacity. It's not the patient who is seeing something. So we definitely need to rethink how we approach cataract. Cataract, everyone approaches it, and we're trying to classify it more, and for 30 years or more now, the LOX classification has been there. And the new classifications also are trying to approach what the structure of the lens, not the functional. So we do need a functional classification, a functional definition, like that of dry eye. Dry eye, they have the function of the eye in it. We do need this now. Thank you very much.